Time for another Puscast, this one covering the first 2 weeks of January 2016. References, of course, are available online at edgydoc.com, where you can find links to my growing multimedia empire. And just so you can get all anticipatory, Volume 2 of the Puss Whisperer will be out soon. I just got my author copies, so it should be available on Amazon. I'm sure you're all excited. And you all recognize, of course, that the Puss Whisperer, Volumes 1 and 2, make wonderful gifts. Now let's move on to the literature, shall we? I don't know. It just seems that this century we are having to worry more about the influx of a variety of mosquito-borne illnesses. Chikungunya, dengue, West Nile, and now Zika virus, Z-I-K-A, which is running rampant in South and Central America. It's one of the many viruses to cause high fevers, myalgias, low white count, etc., and should be on the differential diagnosis of a traveler coming from that part of the world. Of note this week, the first case in the continental United States was confirmed in Texas. It was in a traveler who had come through El Salvador. And if a traveler comes through with Zika and he gets bit by a mosquito, well, we may see that become more of a problem in the United States. I'm still putting my money on chikungunya as the first one to sweep the United States, but maybe dengue will come back. Maybe it will be Zika. Now, the big issue with Zika is that in South America, it's been associated with microcephaly, and as such, the CDC has warned pregnant women not to go to areas where Zika is endemic, just so pregnant women are aware that if they get infected with Zika during their pregnancy, they may have a Republican presidential candidate. I know, cheap shot, but my God, what a bunch of morons. I'm recording this podcast, at least this particular segment, on January 16th, and looking at the CDC site, it looks like influenza activity is kicking up a little in the United States, although it appears quieter than prior seasons. There's a nice review in Journal of Infectious Diseases on the evolutionary dynamics of influenza A virus in U.S. exhibition swine. And what's interesting is that you have commercial swine where influenza circulates, but they tend to get turned into bacon. But you have exhibition swine. My niece, Annie, when she was young, raised a pig for exhibition, and she named it Uncle Mark. Uncle Mark took a blue ribbon. I still have a picture of Uncle Mark. But people take their swine for exhibition, so flocks of pigs, do pigs come in flocks? Mix, and so they share influenza back and forth. Not only do they go from the farm to the exhibition, but they go to different states. So exhibition pigs are the vector by which influenza escapes flocks of pigs, and also how it goes then unto human beings. And there's been lots of documentation of influenza going from exhibition pigs to humans. And of course, the mixing of pigs allows lots of viral reassortment for new strains, which is partly where the H1N1 came from. And there's a bunch of nice reviews in the New England Journal of Medicine about this a couple years back. Whenever we go to the county fair, and we go every year, we have to go look at the baby pigs. They're so cute. But if you see one sneezing or asking for some airborne, you know that you got a problem and you should stay away from them there pigs. As long as we're on the topic of influenza, as you may or may not know, there are two strains of influenza B circulating. There's the Victoria strain and the Yamagata strain. Is there any difference in disease or influenza resistance in these organisms? And the answer is no. They act the same clinically, and resistance is still unusual. So influenza B, whether you have Victoria or Yamagata, is the same. And finally, the vaccine used predominantly in children, the live attenuated vaccine for H1N1, is not as good as the shot in a recent study. So as new cohorts of children are born without influenza protection, if you want to prevent your kids from getting influenza, the live attenuated vaccine is not as good, and you should probably consider making sure they get the shot, or as they call it in the United Kingdom, the jab. I still don't know which sounds worse. Do you want to get a shot or do you want to get a jab? I'd rather get a shot than a jab. A jab sounds painful. A shot, not so much. It's what whiskey comes in. An interesting natural experiment in the treatment of Ebola. Patients coming in with Ebola got treated for malaria as well in Liberia. Some patients got artemether-lumefantrine, but they ran out of it. So other patients got artesunate and amiodarone. It turns out amiodarone has some Ebola activity. So when they looked at the outcomes retrospectively, those who got the artesunate amiodarone had decreased mortality, 50%, versus 64% in the other group. And it was more pronounced in patients who did not have malaria. And it turns out that amiodarone has some anti-Ebola activity. So this may be an antiviral effect of what was given as an anti-malarial. Although it may be that this medication was less toxic in patients. So are they seeing a benefit because of an anti-Ebola effect, or a benefit because the combination is less toxic than the standard treatment? Artemether-lumefantrine is contraindicated in patients with low magnesium or low potassium because it leads to QT prolongation. And given the derangements of electrolytes that are part and parcel of severe Ebola, maybe they were killing more people rather than saving some by giving them an antiviral. Personally, I bet they just killed fewer people when they gave the alternative regimen, but we'll see. It's always difficult to remember, in at least the back of your mind, that vaccinations for infectious diseases is both beneficial at the individual level, but also at the population level. And when a certain percentage of a population has immunity, disease does not spread. But that does not mean that individuals who have had vaccines are at zero risk for acquiring infections. Take measles, please. They looked at the secondary cases of measles in healthcare workers in the Disneyland outbreak. There were 5 cases in healthcare workers, 4 of whom had direct contact with patients, none of whom wore N95 masks. But here's the problem. 4 of the 5 had evidence of immunity, but they still worked after getting infected and resulted in 1,014 exposures, but interestingly, no transmissions. So maybe vaccination prevented the spread of disease, although it did not prevent the spread of infection. But if you're going to see a measles case, you really should wear an N95 mask. And who knows, there may be a lot to be said for getting constantly reboosted with measles by being exposed to infected cases, as occurred back in the day before the vaccine, at least in prevention of getting a second case of measles. But it's certainly not worth it to have huge cases of measles with the resultant deaths. I still have not seen a case of measles in my career, but I expect one of these days I will. I have very old immunity to measles, as I was in the measles vaccine trials back in the early 60s. And to my knowledge, I've not been exposed since. As the skeptic in me always likes to harp on, the plural of anecdote is anecdotes, not data. And a case series of 3 patients is little more than anecdotes, but interesting nonetheless. This was 3 patients with iris secondary to mycobacterial infection. They were given steroids and didn't get better. So they were given infliximab, a TNF-alpha inhibitor, much more expensive than prednisone. But not only did their iris symptoms due to mycobacterium go away, but there was no adverse effects on their response to their HIV medicines. So it would appear, based on 3 whole cases, that it was safe to give infliximab to patients with MTB iris. They did not get their TB worsened, nor did they get their HIV worsened. They did, however, go bankrupt. I don't actually know that's the case, but a dose of infliximab is about $2,000, and patients can be billed as much as $15,000 for a dose of the medication. Prednisone's a wee bit cheaper, but if you're not responding, what are you going to do? Both my boys are HPV vaccinated. As soon as it became available, I paid for it. How common, though, is HPV? Remember, it's a very common illness. And in this serologic study, 40% of females and 20% of males had serologic evidence of one or more of the HPV found in the current vaccine. I know you think that little Timmy and little Samantha are never going to be sexually active, but they are, and you're not going to know about it, and they're going to get HPV, so you might as well get them vaccinated now. Actually, it's little Liam and little Emma, since those are evidently the most popular names for babies currently in the United States, followed by Noah and Olivia, Ethan and Sophia, Manson and Ava, Lucas and Mia, Logan and Isabella, Oliver and Charlotte, Jackson and Amelia, Aiden and Harper, Jacob and Madison, Elijah and Emily, James and Abigail, Benjamin and Avery, Alexander and Lily, Jack and Ella, Luke and Sophia, Carter and Chloe, William and Evelyn, Michael and Aria, Daniel and Aubrey, and that is the top 20. Mark isn't even on the list. Boy, kids today just don't know how to name their children. But regardless of what you name them, they're going to get HPV. Get them vaccinated. It's a hell of a lot less than infliximab. I always snicker when I see the sign at the grocery store, fresh frozen fish. It's still frozen. How about poop? How's fresh frozen poop? Well, it turns out that fresh frozen poop is just as good as fresh poop in the resolution of C. difficile. This was published in JAMA. We were really in a race to come up with the most convenient way to give poo pills, or in this case, poosicles, to people so that they don't get C. diff and we can treat C. diff. I suspect, and I still haven't seen a clinical trial, and hopefully someone's doing it, using poo pills instead of the usual probiotics in patient on antibiotics to prevent C. difficile diarrhea. I think that's going to be an even bigger use for the medication if we can get some clinical trials. But is it going to be artificial poo, frozen poo, fresh poo, Winnie the Pooh? I just can't wait for a convenient, easy way to deliver poo to my patients. Besides, of course, this podcast. So where did Helicobacter come from? Well, by genetic magic, it's estimated that it came out of Africa with humans about 100,000 years ago. But the current strain of Helicobacter is a mix of both African strains and Asian strains. So when did this happen? Well, it turned out that Otzi the Iceman, the frozen copper-aged mummy, had Helicobacter. So they biopsied his stomach and they ran the genome of the Helicobacter in this 5,300-year-old mummy. And they found it was almost a pure Asian form of Helicobacter. So going back 5,000 years or so, the Helicobacter that was infecting Otzi the Iceman was Asian. So when it mated with the African strains is still unknown. This is the kind of stuff that just makes ID so cool. I love these ancient archaeological investigations of infections. Well, it's not an ancient investigation. It's an investigation of ancient infections. You know what I mean. Medscape had a thing on doctor burnout, and ID docs tend to be burned out more than other doctors, and I just don't get it. It's so much fun. Of course, I have a unique job, so who knows. I hope there's a special place in hell for people who do this sort of stuff. There were a couple of cases of deaths in Africa from meningitis, and when they checked the ceftriaxone they were getting, there wasn't much ceftriaxone in the vial. It was labeled as 1 gram, but it was under half a gram of the antibiotic. So some bastard is selling substandard or inadequate ceftriaxone in the third world. That is just awful. The issues of counterfeit and inadequate antibiotics in Africa and other third world countries is tremendous and particularly loathsome that people would do this to other human beings. I always tend to think of human beings like Pigpen from Charlie Brown. We're all in a haze of bacteria and shedding skin. I mention this only because what are the risk factors for developing a resistant urinary tract infection? Well, if you had exposure to a person who recently returned from an area with a lot of antibiotic resistance, when you get your urinary tract infection, it will be to a resistant organism. That would be places, I suppose, like India and Boston, Massachusetts. Anybody who thinks bacteria stop at the orifice are fooling themselves. It's long been known that UTIs get better on their own. If UTIs were progressive and fatal, we would have never evolved out of the trees, since most women get at least one urinary tract infection in their lives. There have been studies to suggest that symptomatic treatment with ibuprofen has the same effect as antibiotics. In this study, most women who had a UTI who had ibuprofen got better. However, if they didn't get antibiotics, they were also more likely statistically to go on to develop pyelonephritis. So the real question in a symptomatic urinary tract infection is who is going to progress and who will get better on their own, since we have no way to determine that. But the vast majority of patients will improve on their own without antibiotics. And perhaps what's needed is a delayed antibiotic approach to urinary tract infections. But you probably want to do that only if you have really good malpractice insurance. And what is the effect of removing stones in patients with symptomatic UTIs? Well, you'll decrease their recurrent UTIs by about 50%. So unfortunately, removal of kidney stones is not the be-all and end-all of preventing recurrent UTIs. Well, I always rant that there's no such thing as a strong or big gun or a powerful antibiotic. There are certainly antibiotics that stink on ice, and vancomycin is an archetype. I so want to give up using vancomycin for anything outside of C. difficile, but I certainly don't like treating staph infections with it. It's toxic, it's inconvenient, and it doesn't work. Plus, we really don't know what we're doing sometimes. For example, there was a study that looked at the outcome of MRSA pneumonia in patients who had vancomycin heteroresistance. What does that mean? No, it does not have to do with gender typing. Heteroresistant is a Staph aureus that appears initially sensitive to vancomycin, but it kicks out daughter cells with slightly higher MICs, 1, 2, 4 kind of deal. So that there are subpopulations that have more resistance than the predominant population. And those patients do poorly with vancomycin when they have pneumonia. They have higher mortality rates. So you can't tell as a rule in the lab if you have an H. visa or not. So probably you should go with something else like linezolid or ceftaroline. I so want to give up on vancomycin. Another interesting option would be a combination of vancomycin plus another drug. Now, methicillin resistance is not an all or none phenomenon as much as you'd like it to be. And vancomycin shows synergy with nafcillin, or beta-lactams of all things. So what's the result clinically? If you give patients with MRSA bacteremia vancomycin versus vancomycin and, in this case, flucloxacillin, you find that the beta-lactam vancomycin population had negative blood cultures faster, 1.9 days, versus vancomycin alone, 3 days. Unfortunately, the endpoints of metastatic infection, nephrotoxicity, hepatotoxicity, and 28 and 90-day mortality were unaltered. So perhaps a combination of vancomycin and a beta-lactam is more akin to rearranging the deck chairs on the Titanic so it looks prettier. There's still something to be said for doing something other than vancomycin or in addition to vancomycin, given what a horse crap piece of antibiotic it is. Here in Portlandia, one of the things we've always been proud of is our elephants. I'm particularly pleased because we had an outbreak of tuberculosis in 3 of our elephants and a human contact. This was reported in the MMWR. This is not the first time humans have gotten TB from elephants or vice versa. There was an outbreak, I believe, in Tennessee, and something like 2/3 of Indian elephants are positive for at least latent tuberculosis. So there are many animals that can get human tuberculosis, including elephants and seals, amongst others. It doesn't look like they ever found the source of the TB in the elephants, whether it was other elephants or humans. And I guess they do trunk washings looking for TB in that specimen. I think it would be hard to induce a sputum in an elephant. as long as you're treating tuberculosis and you get TB meningitis. Just so you know, the study in the New England Journal of Medicine demonstrated giving intensified therapy, higher dose rifampin plus levofloxacin, was no better than standard therapy for the treatment of TB meningitis. So you can continue to do what you've been doing for the rare case of TB meningitis that you see in the United States. So let's say you have a fungemic patient in the ICU, Candida albicans. You appropriately start them on an echinocandidin and they do well. When should you step down to fluconazole, which is a lot cheaper? Well, it looks like if you do it about day 4 or 5, patients do just fine as long as they're clinically doing well. So if your patient responds to therapy and is doing well at day 4 or 5, it's time for fluconazole. And probably in a mostly normal host, the patients will do fine as long as you give the immune system a nudge in the right direction. Pythium insidiosum. It sounds like a Harry Potter curse, but no, it's human pitheosis, which I have never heard of before. What is pitheosis? It is a, quote, haploid eukaryote belonging to the Oomycetes that is closely related to brown algae of the phylum Phaephatia. In tissues, it looks like mucorales. It's found in Thailand in water and decaying organic material. And pythium derives from the Greek pythian, meaning to cause to rot. Evidently, there have been about 102 cases in Thailand over the years, cutaneous, vascular, ocular, disseminated disease, and there's a couple reviews out. I've never heard of pitheosis. What would you treat it with once you figured out that this person from northern Thailand had a cutaneous disease that was pitheosis? Quote, recent studies have demonstrated azithromycin, clarithromycin, linezolid, mupirocin, doxycycline, minocycline, and tigecycline have in vitro activity. Azithromycin with or without minocycline is effective in the animal model. 99% of the people listening to this Puscast probably won't care. I assume maybe 1 or 2% are going to have to do their ID boards. This is the kind of Harry Potter curse that will likely show up. Not that I have any inside track, mind you. I just think that way. Large swaths of the boards consist of things that you never see and never take care of. And really, the correct answer should be Google it. Notice that smell? Do you smell the bullshit? Here's an article. Use of oritavancin in acute bacterial skin and soft tissue structure infections, patients receiving intravenous antibiotics, a U.S. budget impact analysis. So these people, and I do not know if the oritavancin people sponsored it, Nichols says they did, looked at oritavancin and found that it would be cost effective and that if you treated 1,000 patients receiving intravenous MRSA infections for skin and soft tissue infections, you would save a serious chunk of change. Oritavancin costs $3,500, $4,500 a dose, a fully loaded MacBook Pro. Seriously, if you have 1,000 patients with acute cellulitis that you're treating for MRSA, or even 26% of those patients you're treating for MRSA, you don't know what you're doing in the treatment of a soft tissue infection. Acute soft tissue infections are strep and MSSA and maybe Staph leugninensis. But so often people get MRSA therapy that they absolutely positively don't need. And most staph abscesses only need debridement with a little oral follow-up. Seriously, if you're treating that many MRSA infections in your community, you don't have any idea what you're doing. This is, yeah, I smell it. Yeah, bullshit. Because the biggest problem with the treatment of skin and soft tissue infections in the outpatient setting in the ER is people don't know what the hell they're doing. It's appalling. And that brings us to the end of the first Puscast of 2016. References are available online, and if you're using the iTunes download, you can see it in the window, a list of all the articles I've talked about. Otherwise, go to edgydoc.com for my growing multimedia empire. And of course, write me write me glowing reviews on iTunes. I swear I'm getting senile. Otherwise, as always, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. Thank you. In dictation, goodbye.